Welcome back, ladies and gentlemen. We've now come to the second plenary session of the day, Precision Public Health in Low and Middle Income Countries, kindly brought to you by gold sponsor SysMed. This session will address the challenges faced in bringing precision public health technologies to low and middle income countries and discuss opportunities and solutions surrounding resources, national policies, and international collaborations. Moderating this session is Professor Tikki Pangestu, Visiting Professor at the Department of Medicine in the Yong School of Medicine at NUS. Prof. Pang joined NUS after 13 years at WHO as Director of the Department of Research, Policies and Cooperation. In this capacity, he worked with countries to strengthen their national health research systems, develop mechanisms and initiatives to improve the efficiency and transparency of global health research, and help formulate an organization-wide research policy. He was also Professor of Biomedical Sciences at the Institute of Postgraduate Studies and Research and Associate Professor and Lecturer at the Faculty of Medicine at the University of Malaya in Kuala Lumpur, Malaysia. I would now like to invite Prof. Pang to introduce our speakers for the session. Prof. Pang, please.
For your kind introduction. As Kisha mentioned, I worked for the WHO, part of that time under Dr. Margaret Chan, who spoke this morning. So this topic of precision public health in low and middle income countries is of particular interest to me. And I think we are very fortunate to have an extremely knowledgeable panel this morning. And in the context of that theme of precision public health in low and middle income countries, the sub-theme for today's session is that the future is already here. Okay, and I hope that for the next hour and a half, we'll be able to sort of get a bit of a taste of what that future might be. Because I think there is still perhaps a lot of misperception about what is precision public health, especially in the low and middle income countries. It's often confused with precision medicine. People have this perception that it's expensive, that it's high technology, and maybe has little relevance to public health, especially in the context of what's going on with COVID. So without further ado, to sort of set the scene, with sort of a little bit of an overview, I guess, it's my pleasure to introduce Andrew Trister, who is Deputy Director for Digital Health and Innovation at the Bill and Melinda Gates Foundation in Seattle. He had previously worked with Apple in areas of clinical research and machine learning. So we hope that Andrew will set the scene in terms of precision public health for the world. So Andrew, over to you.
Great, thank you, Professor Tikki, and thank you to the organizers for the opportunity to share some of the thinking with respect to precision public health. So good morning to you all. As you've heard, I lead the digital health innovation team at the foundation, and I am a clinician scientist. And so I've been interested in exactly these ways that we've been using data increasingly in our clinical practice and find ways that we might be able to impact care that we deliver to patients. And the story that I'd like to tell this morning really begins over 100 years ago with the Circle of Hopkins. And so here I see Sir William Osler on the left and Abraham Flexner on the right. So it is an odd thing to begin with a precision public health talk in LMICs with a US history lesson, but I do think that a lot of what we see in the world right now goes back to this event of the Flexner report. So for those of you who may not be familiar, in 1909, Abraham Flexner produced a report for the Carnegie Foundation on the education of medical education with an idea to improve laboratory practices and reduce the variability across many different types of medicine that were practiced at the time. And the American Medical Association, which is really a lobbying arm for allopathic medicine, picked this up in 1910, and it led to the March of Science in the practice of medicine. Osler, who was on faculty at Hopkins at the time alongside Abraham Flexner, he was not opposed to the better inclusion of science information, but was most critically focused on the patient's story. So for those who have studied medicine, there was already this sense of how could we use data to better inform the clinical decisions. And Osler famously talked about bedside teachings as the art of the history and physical, that the patient will tell you their own diagnosis. And the Flexner report, in its effort to codify the quality laboratory practices, really led to establish programs across medical schools and eventually in the federal government. And so here we see President Truman signing a health bill in 1946. And this was really meant to establish all of the health programs within the federal government for all employees. And notably here, surrounding him, watching him sign, are the Surgeon General, the President of the Civil Service, and the Federal Security Agency were all there. And so we highlight this because when we think of the needs of the populations, right, as the Surgeon General's mandate, as well as for civil service, and the need for security, all of these things come back to how is it that we look at the data that are collected within the medical practice and how could they result in better care. And so over the following half century, what we really saw was a drive toward more research, pulling practitioners out of the community and focusing more and more care in high demand referral centers. And so this fictitious doctor, Marcus Welby, from the 1970s television program, led away from community-based care and more toward tertiary or quaternary care, here epitomized by the Texas Medical Center in Houston, shown on the right. So these scientific advances continue to accumulate, and we started to generate more data about disease than about the system in which people are seen. We understand more, since the mapping of the human genome 20 years ago, touted as a scientific breakthrough, and truly has led to incredible changes in the way that we manage disease and our understanding of different conditions. But we have lost the understanding of the most minute societal changes all around us that have had implications around care and disease. And so to this end, I was reminded in preparation for this talk of a physical model, Galton's quincux, which is represented here. And the concept is that any random process, here they're small beads that are shown on the left on the bottom. And as you flip the quincux over, they kind of pass through the various pegs. And depending on how you set the pegs, you can approximate different statistical accumulations on the bottom. So here is shown a nearly binomial normal distribution simply by having pegs that are normally distributed. There now have been physical models that have shown that you can get a log normal distribution or binomial distribution just by changing the pegs. And if we think about this as a model for individuals attaching to a health system, looking for their own care in their own random walk, as very often happens to be the case, what we end up getting on the population side, we think of as these normal distributions or some statistical accumulation, but we lose the individual component of each of these people hitting the health system. And too much of the systemic biases that exist now that have become so evident across the world, thanks to the pandemic that we have been living through, result in a totally different distribution in the end. So by looking at individual traits that drive these decisions and focus on how individuals will improve, we lose focus on the system that underlies it and these biases. And so with the advent of the genomic revolution, we had really begun to push forward a concept of how could we take some of the ideas, just as Prof. Tikki was talking about in the kickoff, to go beyond the genomics and to start to address ways that we might be able to look at these differences in the system and to invent the precision population health. And the previous CEO of the Gates Foundation, Sue Desmond-Hellmann, had really touted this as a revolutionary change within the work that we were doing in LMICs. And in 2016, she had an editorial in Science that focused on the potential impact of precision population health and ended that piece with this quote: that we have the tools to bring the right interventions to the right people in the right places to save lives. Now we just need the will. The first part of this quote I'll highlight relates directly to this idea of providing better care to individuals. But this call to action that followed this at the Global Health Assembly in 2017 were really to do four things: to register births and deaths, to link those registries to health records, to track disease, incorporate laboratory analyses, and train more people in data science and epidemiology. And again, we have seen that these efforts have not gone as far as they could have, but digital tools have become introduced in a number of countries, and that is where we started to see a piece of the puzzle falling together. And so when I joined the foundation a year and a half ago, my mandate was really set forward to drive digital applications. And on this slide, it's a bit wordy, so let's just walk you through. Our idea was to take this idea of looking at the individual care that's produced in the communities where people are seen at the very first stage, the frontline health worker, and begin to build interoperable systems so that the entire fragmented solution from patient all the way back to public health infrastructure can allow for data to flow, and thereby aggregating not just the systemic components that we see now in the existing systems, but in fact all the way down to individual level traits, so that we don't lose some of the components that we were seeing with respect to this precision. This idea that there was a fragmented ecosystem of apps and systems is not unique, but the concept that we have begun to work on just at the beginning of the pandemic were really focused on four product areas shown here. So the idea that a beneficiary or a beneficiary and their child could be seen in their home, in a health post, in a private sector community-based care, and ultimately in a facility, and that we would be able to provide concepts around leveraging this existing workforce in the community, augmented with digital tools, and provide prevention, monitoring, clinical assessments, or triage to lead to better actions on behalf of the individual, and focusing on risk assessment primarily with connected diagnostics and objective measurements as a benefit, and ultimately tying that all together with incentives to drive the actions that make the most sense on behalf of an individual. And ultimately, this entire platform, which shown here in the dark blue, aggregates these data in a way that could be actionable for resource allocation at the highest levels. The COVID pandemic over this past year has given us an unprecedented opportunity to accelerate some of these infrastructural changes, but also showed us the schisms that lie between medical care and population health management in so many parts of the world. And so to focus on one small area that the team worked on this past year, we had focused on this idea of having a digitally connected diagnostic to better inform individual management as well as population management. And so in a very, very simple way, we thought about ways of testing for, in this case, for SARS-CoV-2. And we think of the incentives or the reason that a person might present. And so certainly there is a patient care incentive. So approaching a health system, having traits of COVID, one should have tests that are done, and these should be high sensitivity, and getting a treatment potentially. There are, and these are not in a regulatory frame, the way that people have looked at testing, but we have been arguing for some time about the need to interrupt transmission. And so detecting those people who are most likely to transmit virus, rather than simply finding whether a person is positive molecularly with, say, virus on a sample from the nose or oropharynx. And this concept of transmission interruption has much more of a population feel than it does an individual feel. And so while somebody may have positivity on one form of test, if they are sequestered or potentially not doing other activities that may lead to, say, a super spreading event, then the transmission is very unlikely. And so we would worry less about that in terms of risk. And then, of course, there's the general sense of epidemiology. So being able to look at population risks and positivity and understand trends, especially as there are population relative reactions to the condition. So the issue that we've had here is that there hasn't really been a mandate around a number of these different tests outside of patient care. And further, an emerging use case that we didn't even anticipate in the beginning was really around travel and border crossings for economic activity. And in places like sub-Saharan Africa, we have seen that the vast majority of the tests that have been performed have really been done at ports of entry or at border crossings. And that could have been expected given the economic toll that the pandemic was having and the really rudimentary tools that we had at the time. But it is shown that there really is a very limited mandate at the level of public health and government to take on some of these other components. So we have been looking at the various positions where a person may come in, trying to provide them access to tools that allow them to either self-administer a test or to be seen in the community, to be tested either with a lateral flow assay or molecular test with PCR, but to ultimately drive those test results for better actions for those individuals and for the population as a whole. So coming back to this quotation from Sue Desmond-Hellmann, we see that the world has shifted thanks to COVID. And I think we're really now faced with this question that Sue ended with in her editorial 5 years ago. Do we have the will to act? And this idea of innovation bringing the present closer to the future is really the area that I would like to pose for our panel and that we are continuing to struggle with within the foundation. We think through questions around who pays and how much. We've recognized that prior to this pandemic, the pandemic preparedness spend globally was a very, very small fraction of world GDP. Is it sufficient to look at pandemic preparedness as a driver to make connected public health infrastructure a reality worldwide? We also recognize that there are shifts in the beneficiaries, and particularly, are we able to talk about the benefits that can accrue to those who are furthest down on the pyramid, and to ensure that those with the least can still have the benefits of any of this infrastructure. And this is really at the core of most of the work that we have been undertaking and trying to subsidize. And then we also think about who suffers. And just as we had talked about earlier today, the structural inequities that we saw, particularly those in rural or poor neighborhoods, the elderly and ethnic and racial minorities throughout the world have seen the fewest benefits of many of these tests. Now, there are systematic issues with respect to accessing care for many of these groups as well. And so we recognize that the care paradigm, especially around testing, but access through digital means, may not necessarily resolve a great deal of these inequities. And so this is a lot of the policy work that we see going on. And then, of course, there's a question of who profits. And this has been most evidenced recently with the vaccine debacle, with high-income countries fighting one another to get access while low-income countries remain waiting. And so in this vision of how we can get to the future with precision population health, I think that we can define it very well, and we already see, just as Professor Tikki mentioned, that the future is already here. The key, I think, for many of us who are working in this space is to ensure that the future can be brighter for those that may not have a voice at the moment, and how to bring voice and agency to those without it is more than just the technical. The technical problems are solved. It really does come down to many of the policy and mandates that those esteemed colleagues here on the panel with me have been working on for quite some time. So with that, I thank you again for the opportunity and looking forward to the discussion.
Thank you very much, Andrew, for that wonderful and succinct and informative overview. I was particularly struck by your slide where you illustrated how patient care is now linked to transmission interruption and to epidemiology. I think that captures in a nutshell how precision public health at the individual level is now very closely linked to population issues as well. And I'm particularly struck by the relevance of, for example, rapid genome surveillance technology in terms of detecting the SARS-CoV-2 variants. Okay, I think that's a particularly good example of how some of these so-called precision tools are actually being used in a very contemporary manner to look at transmission and to look at epidemiology, and of course, ultimately at prevention. So thank you for that. So we now have the privilege to go into the panel discussion, and I thank Andrew again for providing some very interesting questions to the panel. Who pays and how much, who benefits, who suffers, and who profits. I will give the panelists some time to consider maybe addressing some of those questions. But in the meantime, let me begin the panel discussion by introducing Patrick Gladding from New Zealand, who's a cardiologist and a founder of Theranostics Lab. And in a way, it's a nice segue because I think Patrick's going to tell us a little bit about a surveillance program for COVID-19 and NCDs in the context of New Zealand. So that's a nice segue from what Andrew presented. So over to you, Patrick. Please unmute yourself.
Thank you very much to the organisers for the invitation to speak. I can't speak for all of New Zealand in our approach to COVID-19, but we've been very successful here in managing the pandemic by essentially eliminating the virus from our nation by closing our borders. But it has triggered a lot of activity, particularly in the innovation space. And what I'd like to do is present a case study of a program that's operating in our hospital, which should be very complementary to what Andrew's been speaking about. So this has been done really just within our one hospital, and we have 24 major district health boards within New Zealand. We consider this a surveillance program, not up and running, but one that could be. So we're really looking for the opportunity to collaborate. So anyone interested in learning more about this, please get in touch with me. We call this program Pattern Recognition of Global Responses and Monitoring. Next slide, please. This is the hospital in which I work. It's Waitemata DHB, District Health Board. We serve a population of around 600,000 patients, and there are more than 1 million patient encounters per year. New Zealand sits probably in the midway of the OECD, so middle income country, definitely. We have a socialized healthcare system, and our major problems are we have lack of access to really high-end diagnostic imaging, procedural technologies, feel often resource constraint is a big issue, and as a result, we have relatively long waiting lists. And the hospitals are so busy, really, they only really consider what's happening on a daily basis without actually being able to plan forwards. And I think at any one time, it would be quite difficult for the hospital to know what's actually happening at the individual level. So within our Department of Cardiology, we decided, since we'd been collecting masses of electronic data for over 10 years, to aggregate this. And we formed a very large metadatabase of around 100,000 cardiac patients. And what I'll speak of now is limited to a small subset of that, of just the laboratory tests, given that they're so abundant and complete, as well as the diagnostic coding and genetic testing. Next slide, please. So within our laboratories, we have a Sysmex hematology analyzer, as many laboratories do in our country and around the world. And these analyzers produce an absolute wealth of information, most of which clinicians don't see. We may see maybe 7 to 8 bits of results on a patient, hemoglobin, white cell count, etc. But there's actually hundreds, if not thousands, of extra parameters that could be extracted from these instruments. And most of it's discarded. So early in the pandemic, we built a rapid turnaround PCR-based COVID-19 test, really the first uptick of the pandemic. And we're running this as a point of care, nearly diagnostic. to make early diagnoses and to keep people in the community. We matched that against the results from this hematology analyzer and started looking at whether we were able to predict certain things like age, gender, and on the right here, the actual individuality of each person. So these clustering here of different colors are one person's blood test over a number of weeks, if not months. And you can see how much of a fingerprint, much like a retinal scan, a fingerprint is for each of these patients. And actually, what we could see from this data was you could predict the presence of COVID-19 infection to quite a high degree of certainty, and even more so heart failure. So almost to the same accuracy as most of our standard diagnostic tools, as you can see there with the receiver operator curve. Next slide, please. So these analyzers are actually scattered right across our country. They're in 85% of all laboratories. And by networking them together, there's the potential of actually monitoring an entire population. Something such as this could be a bird's eye view of an emerging epidemic or pandemic in the future. Certainly, as we've shown with heart failure, could show regional differences in prevalence of disease. We're not sure even yet how much more we can get from this data. Well, this project's brought up a lot of issues around the use of big data, unconsented data, accessing the right skills to use this data appropriately, the ethics of using it, ensuring that you don't worsen disparities by introducing bias. And of course, there's the issues of security and social contract. But all in all, I think this is very consistent with what Andrew was saying. The technologies are now here to do things at scale like this and very cheaply. Each of these tests is less than $3. But there just seems to be the lack of willingness. So that's pretty much all I had to say in opening up to questions. Thank you.
Well, thank you very much, Patrick, for that wonderful case study. I think what I took away from that is the potential, the immense potential of using your approach, not just for tracking, infectious diseases, but its application in NCDs, which, as we all know, in many of the lower middle income countries are becoming a double burden of disease. So any future tools that will help will once again promote the value of precision public health beyond just infectious diseases. I think we are all aware of the wonderful record of New Zealand, and I just heard on the news yesterday the historical first ever travel bubble between Australia and New Zealand, and I think many countries will be looking to emulate that. So thank you very much. Let us move on now, and as I said, I'm moving now to the other panel members, and I've given them the freedom to make whatever intervention they want, either responding to Andrew or to Patrick or highlighting some other important issues. So moving to Olivo Miotto, who is at the Mahidol-Oxford Tropical Medicine Research Unit in Bangkok. And Olivo's sort of work in a very important area that I've been following a little bit, and that is in the genomic epidemiology of anti-malarial drug resistance. So over to you, Olivo. You're muted, Olivo.
All right. Thank you very much, and good morning, everybody. Thanks for that introduction. I would like to talk about some of the realities of implementing genetic surveillance in the Greater Mekong subregion, or GMS as we call it. I'm the principal investigator of GenRe Mekong, which is a large-scale project that conducts genetic surveillance of malaria parasites. And thanks to 𝗦𝗦 for giving us a shout out in the earlier session. We are funded by the Bill and Melinda Gates Foundation, and we work with malaria control programs in the Ministry of Health of the various GMS countries, with the goal of informing their decision-making and basically optimize the path towards malaria elimination. Malaria is, you can think of it as the archetypal low and middle income country disease. It mostly kills children in African countries. And by comparison, in Southeast Asia, we have much lower mortality. But paradoxically, the interventions in Southeast Asia have great impact worldwide, including on those children in Africa, potentially. And this is because Southeast Asia, over time, has been repeatedly the epicenter of the emergence of drug resistance to antimalarials. And we've lost major drugs like chloroquine and sulfadoxine pyrimethamine and so on in the past. And right now there's very much an ongoing threat that this is going to happen again with artemisinin, which are the main frontline drug. And if this spreads outside of Asia, it could roll back the great progresses have been made in the last few years. So, you know, in the earlier presentation, there was the great quote that we have the tools to provide the right interventions to the right people in the right places. And in the GMS for malaria, the right intervention means that national malaria control programs must use effective drugs that will prevent the spread of resistance to the rest of the world. This might seem a very basic application of PPH, but in fact, the reality in low-income countries is that a lot of the basic information flows are just simply not there at the moment. So right now, the control programs don't have very efficient ways of knowing about resistant strains and whether they're spreading. In the last 5 years, we have seen a dramatic example of this, you know, with a strain of parasites resistant to both artemisinin and piperacin emerging in Cambodia, and because all the neighboring countries, bar Laos, had adopted exactly those two drugs as the frontline therapy, there was a very rapid and incredibly penetrative spread of these drug-resistant strains across borders. So, so the question is, can we give control programs the right tools? So our project collects blood samples from the health centers in the remote endemic areas of these countries, which are actually sort of hard to access. And we use genomic technologies, high throughput, in order to detect basically a whole panel of drug resistance mutations and then report their prevalence to the control programs. Now, we have now done this in all of the countries in the GMS, and we've processed about 15,000 samples already. And this is continuing in some countries, in most countries, actually. We are now doing this routinely and have incorporated this process in routine malaria treatment. Now, what I wanted to highlight is that in order to do this, we really had to make the process simple enough. And I don't think this can be stressed enough. In these settings, technology is very limited. And I'm not talking about having a sequencer on site, and I'm not talking even about mobile phones. I'm talking about whether there is even a refrigerator to keep a blood sample in. So it was very important for us to be able to sequence from a dried blood spot that could be kept for a month at a site inside a little plastic bag with some silica gel. And then we had to simplify metadata collection so that it would require minimal training to get the samples. And then we had to bridge the knowledge gap to the control programs such that we would employ sort of fairly simple and somewhat blunt visual instruments in order to convey the messages back, because basically public health officials in these countries don't have a background in genetics. So ultimately, it's very much about simplifying so that you can integrate. And actually, we've had some success stories. The Lao authorities, for instance, did not switch to 𝗣𝗶𝗱𝗃𝗃 as a frontline precisely because we showed them that these parasites were coming over the border and it would be unwise. And in Vietnam, some provinces where we work were reclassified because they didn't know they had resistant to artemisinin in there, and we revised that. And so this is something we are able to achieve because basically genetic surveillance gives us results fast, much faster than basically clinical efficacy studies and so on. But of course, even once these countries have these data available, there is still very onerous for them to change policy. So this is another issue that low-income countries are facing. And just to complete the picture, moving forward, what we are hoping is that the same processes of sequencing can also give us information that, for example, will tell us about importation of samples, that will tell us about the nature of outbreaks, and so on. So we hope to be able to extend this to give a more complete picture to the control programs. Thank you.
Thank you very much, Olivo, for that wonderful exposition of anti-malaria resistance tracking. I think once again, it illustrates very nicely what Andrew mentioned before, at the level of the patient, then moving along to transmission and to epidemiology. In this case, not just genomic surveillance of viruses, but genomic surveillance of resistant forms of the malaria parasite. I happen to also chair the board for an initiative called the Asia Pacific Leadership Malaria Alliance. The target was malaria elimination in the Asia Pacific region by 2030. And Olivo will probably know this very well, that there has actually been quite a serious resurgence of malaria during the COVID pandemic. So, the application of these tools, and importantly, making it simple, I think that was another very important point that Olivo highlighted, is once again, I think, going to promote on a very broad front the value of precision public health, especially in those low-income countries in the Greater Mekong sub-region. So thank you, Olivo. Okay, so it's now my pleasure to introduce my old friend Carmen Padilla from the Philippines. Carmen is actually Chancellor of the University of the Philippines, and what many probably don't know is that she's actually a pioneer in genetic screening services in the Philippines, and also a council member of 𝗣𝗄, the Human Genome Organization. So over to you, Carmen. Nice to see you again.
Thank you. Thank you, Dr. Trister, for a very insightful presentation. Now, I agree and support the vision for a mobile platform for clinical care. And indeed, technology is here. Now, the middle income and the high income countries can readily take this opportunity. And as Sue Hellman and reiterated by you, it is just the will. That will must be shared by the different levels in the pyramid, decision makers like the policy makers in government or the corporate ladder. Then, of course, the general public, the beneficiaries. From the perspective of precision medicine as applied to the public health, I agree that there is a need for complicated data systems that can integrate genomic information into clinical data. And the COVID-19 situation has shown the critical role of digital tools. So now allow me to present some challenges for the low and middle income countries. Well, first, despite an appreciation that technology is critical for the delivery of services, low and middle income countries cannot readily avail. Technology will be assessed as expensive, and there will be other health priorities that need greater attention. So it is tough competition. Now, second, in the low and middle income countries, keeping local talent is a challenge. And from experience, even if we have a good number of young programmers, bioinformatics specialists, modelers, molecular biologists, we lose them to other countries with better paying jobs. And there must be a conscious and aggressive effort to train more and keep them in the country, and government must step in. And it's the same story with our doctors and our nurses. Now, low and middle income countries, we've heard it even in the plenary this morning, they need a roster of creative and innovative ideas to hurdle the challenges. Now, these ideas can either be copied from another country or it can be something new, but it must be applicable to the setting of the country. And we need a cadre of professionals or experts to review the options, because these recommended innovative ideas will need the buy-in and support of government for precision medicine, precision public health, or even digital technology to deliver a more efficient, equitable, and better health. My personal take is that if precision medicine is not shared with the general public, then we are not implementing precision public health. Now, in the Philippines, we are fortunate that 10 years ago, our government made huge investments in setting up a genome center, allowing us in this critical time of COVID-19 pandemic to perform sequencing of our samples. And this has helped the government in tracing of transmission of cases as they move. Our first cases were travelers who entered the Philippines last year, and COVID never left. The Philippines has 7,200 islands with a population of 110 million. We have all the variants. And recently we have picked up a new variant, the P.3, that has been picked up in some of our islands. Now, our Ministry of Health has been using this data for decisions for the past several months. This is the first time that our ministry has included genomic surveillance data in their reports. And for me, that is a major development towards a deeper appreciation of precision medicine as applied to public health. Likewise, there's also an appreciation of use of big data in digital tools in the analysis and contact tracing. So indeed, COVID has accelerated the cross-disciplinary engagement of the basic scientists from academia and the policymakers at the Ministry of Health and other government agencies. So here is my challenge. We look forward to the same level of engagement as we tackle the other communicable and non-communicable conditions in the Philippines after the pandemic. But how can we really have the present closer to the future? So let me answer some of the questions. Who pays and how much? There are actually three options for the lower and middle income countries. Honestly, I believe that the best strategy for us is for government to fund precision medicine, public health, precision public health, the efforts, as well as digital technology. Of course, we can have a public-private partnership in the local setting. Foreign support is okay, but if it cannot be sustained in a local setting, it is not really sustainable. Now, a third one, a creative and very feasible option is for a high-income country to share the tools, the technology with the low and middle income countries. So I just want to share with you two short anecdotes. On a personal note, I want to share that the Children's Hospital in Sydney, originally the Royal Alexandra Hospital for Children in Camperdown, during my training 3 decades ago, helped me set up my genetic services in the Philippines. That made a difference in jump-starting the services in my country. A more recent example is when the Genome Institute of Singapore, then under Dr. Edison Liu, guided me in setting up the Philippine Genome Center in 2009. So the big brother, small brother concept does work. Now, who benefits? If the government pays and works for integration in the public health system, then everybody in the economic strata will benefit. When there is a cost, the delivery of service is limited to a sector of society and primarily to those who can pay. Now, who suffers if not equitably delivered? Definitely, if there is a fee, the poor, the marginalized, and the elderly will suffer. Now, who profits? I believe that if equitably provided, the gains will be indirect to the government and direct to the people because we offer better health. So I support the vision of precision public health. This is a very timely discussion, and together let us bring it closer all countries in the region, whether high income, middle income, and low income. Once again, I extend my congratulations to the organizing committee. This is the best time to discuss this topic. Thank you. Back to you, Tikki.
Thank you very much, Carmen, for very nice introduction into the challenges for low and middle income countries. I think we will know very well that most of these countries have not only limited resources, but as Carmen mentioned, competing priorities, and sometimes health priorities lose out to other priorities. The issue of brain drain, I think, is particularly relevant in the case of technologies or capacities in bioinformatics and artificial intelligence. These are skills that are very mobile around the world. So I think that's another important issue. And I like your point that you know, as they say, in every disaster, there's an opportunity. So I think your point that hopefully COVID, despite the huge health toll, will actually accelerate the adoption of these technologies by illustrating, we've already seen that, the value of it in the context of public health. Yeah, so thank you for that. And obviously the sharing between the more developed countries and the lower and lower middle income countries is really an important way forward. Okay, so last but certainly not least, my pleasure to introduce Tarun Weeramanthri from the School of Population and Global Health at the University of Western Australia. Tarun was Chief Health Officer for both Western Australia and Northern Territories, and he is currently President of the Public Health Association of Australia. So Tarun, over to you.
Thank you, Tikki. Lovely to be with you all this morning, and as Carmen says, it's a very timely and important conversation. I just want to reflect on what Andrew said about use cases. So I think that's a very critical part of how we bring technology together with public health. And Carmen described, and others have described, how for genomic surveillance, it's been a particularly convincing use case through COVID-19, whether it's, you know, the analysis of new variants, how they affect vaccines, contact tracing, you know, knowing that this person got it from that other person, etc. Genomics has been at the center of many countries' effective response to COVID-19. And I'd go so far as to say it's possibly the most effective use case for genomics that I've seen in the last 20 years in terms of how it's impacted public health. I think we've struggled to find over the last 20 years, yes, the contribution of genomics to specific precision medicine initiatives, but clearly this is an example of precision public health in terms of how genomics is being used to drive a public health response in many countries through COVID. But just stepping back from that a little bit, and I want to reflect on an experience I had last year, which was being part of a national contact tracing review in Australia. And we all know that across Asia, there's a huge variability in the levels of income between different countries. And our focus here in this session is on low and middle income countries. I'd also say that even within countries, there are massive variations in resourcing. And you see that kind of regional differences. Carmen's pointed that out, even especially in the Philippines. And in all countries, there will be poorer and richer areas, urban and rural areas, etc. And so this whole notion of variability is critical. So what we were asked to do after the Victorian second wave of COVID last year was to review how each of the states and territories was handling contact tracing, because it was such a critical part of the COVID response. But what was different was the partnership that was put together. So a 3-person panel was constructed, led by our chief scientist, Professor Alan Finkel, and also I gave the public health expertise and input, and Lee Jasper was a technology information guru who provided the tech input. So the three of us came from very different backgrounds: science, public health, technology, and we worked together for a couple of months, going around the country and trying to say what was good, what needed to be strengthened, and in particular, how technology could add value to the various contact tracing regimes. The first thing that becomes apparent is how, even in a well-developed country like Australia, how variable the resourcing was between countries. So there's obvious geographic size variation, small populations in big areas of land, pockets of poverty and vulnerability, differences in infrastructure between small and large states, and very marked differences in data capability, even within Australia. What is common across Australia, thank goodness, is a universal health insurance system. So there is a kind of a universal safety net which allows for some lessening of that inequity, at least as it pertains to healthcare delivery. But still, the differences remain. And the other thing that is common is the essentials of the public health response, which have to be delivered wherever you are, whether that's public education or contact tracing or quarantine or whatever it is, or case management, the essentials have to be delivered. And what I would say is, when we went around the country, we had to make sure that we weren't just applying technology for technology's sake. And our tech guru, Lee Jasper, was particularly keen that that not be the case. So you had to say, how does technology add value compared to the current response? The current response led by people with maybe non-technological, expertise, but a good, strong public health response. And then how could technology add value? And some of the best innovations came out of the states and territories with the least resources. And I think that's one of the messages, is that having not a lot of resources can drive a really strong discussion about priorities. And it can actually mean that you use technology smarter. And a lot of our technology innovation comes from trying to have good low tech, if you like, widely used. We often make this distinction between high tech and low tech, but high tech isn't glittery high machines. It's high value technology, and high value technology can be low tech technology, which is widely used and cheap and can be scaled up and can be used robustly in rural areas, for example, rather than just in cities. So there are some kind of drivers. I'll give you the example around contact tracing apps. So essentially, the Australia put in a lot of new money to develop contact tracing apps, which was essentially about having people using their Bluetooth devices on their phone. And then if everyone took up this app, two phones would recognize each other when they passed each other. And then if there was a case, you'd be able to go to that person and say, well, you knocked phones with all of these other people, and therefore we can hunt down your contacts. Unfortunately, for various reasons, that hasn't proved very useful and hasn't been of much benefit to contact tracing. The uptake wasn't great enough, etc. There were technical problems with different mobile phones, etc., etc. And other countries have also had this experience. So that was a lot of money put into a kind of high-tech new application. What was incredibly useful was an existing technology, which is QR codes. And so that's what's been rolled out and has been extraordinarily useful. So now wherever you go in Australia, you use your phone and you log into a restaurant or a shop or wherever you're going with a QR code. And that gives you that's not a proximity. It doesn't require another phone. It just requires you to use your phone and to use your QR reader function. And that is now used routinely across Australia by everyone with a phone, and has proved extraordinarily applicable and useful for contact tracing. So if I am a case, the government can quickly know everywhere I've been, and they can put out warnings to all of those people to go and get tested, etc. So there's a low-tech thing already used, which has proved very useful. So I might stop there, but just to make the general point that I think precision public health is best when it really focuses on the variability, whether that's within countries or between countries, and then uses the most appropriate technology and is very, very strong on what is the use case and what is the value that is added above and beyond what is existing and is the routine practice at the time. Thanks, Tikki.
Tikki? Tikki, I think that you are muted.
Okay, thank you, Tarun. I very much enjoyed your presentation, and I think your very important emphasis on the integration between existing and new technologies and how it should actually be contextualized in the current situation, and also the multiple approaches of the scientific, the public health, as well as the technology. So thank you very much for the panelists for all your contributions to the panel. We have about 30 minutes for Q&A, but before that, I will go back to Andrew, okay, to give him an opportunity perhaps to comment on the previous 4 comments that was made by Patrick, Olivo, Carmen, and Tarun. So over to you, Andrew, for some of your responses.
Thank you, Tikki, and thank you to my esteemed panelists. It's humbling to be among you, to hear about the experiences you've had, and to reflect upon some of these comments. Starting with Tarun, this comment about using technology smarter, I think I'm in violent agreement. I think that this, the learning by doing elements and working with the different regions is one of the core elements that we have been thinking through. And looking at Carmen's comment about the big brother, small brother, that is really, really profound elements with respect to how high-income countries can bring about some change. I would like to highlight there was an opportunity to work in a slightly different way, where we have gone into the world looking for opportunities to reflect upon technologies that have made an impact in lower resource settings, and to see whether those technologies could be transformed. So it's almost like a low-income country to low-income country transfer. And we're in the middle of doing that now with technology used for care delivery and nascent precision public health in the state of Gujarat, where frontline workers in the form of ASHAs and auxiliary nurse midwives are interconnected with the principal secretary of health in the state and all of the levels of care in between. That leads to opportunities to survey antenatal care and the immediate postnatal outcomes of children, to the level that this system called TECO can allow the principal secretary or any of the other public health officials to call upon the health workers, and indeed even the beneficiaries themselves, the citizens, to find out how they might be doing after a tough delivery, as an example. There are opportunities now that we have taken to bring that open source technology in smaller ways in states in Nigeria and in Kenya, and we're exploring ways that this can be impacted in Asia as well, together with the NUS School of Public Health. So these types of opportunities to look at the high value technologies, I think resonates deeply, and both of the presentations from Patrick and Olivo, I think get to the core of this with respect to novel types of information, those things that are generated within the health system and aggregated, just as in New Zealand, or looking at leveraging genomic data for genomic prevalence among parasites. I think that the key for all of these, and one theme that it was sort of embedded within the presentation, but just to bring it back out, is how to take an action. And so the enablement of the true precision public health relates to what is done with the data. So how is it interpreted? First, you have to have it, but how is it interpreted? And then what can be done on behalf of the population? And this too comes back to the context that we hear about. So ensuring that we use technology smarter and that we're able to get to a place that goes above and beyond, just as Tarun was mentioning, also relates to the idea that there is an infrastructure in place and the governmental components that can take these actions. And I think that Carmen had mentioned this very, very well with respect to how government can play this role with respect to payment, ensuring beneficiaries across the entire spectrum, and then reducing the inequities with the services that are delivered. I think just as a point of contrarian component here, and perhaps something that we can get back to with the questions, relates to the role that other sectors may play. So private sector in particular, in the front lines, the potential, just as Tarun was mentioning, of having a multifactorial party, so not just government or public health officials, but indeed, in this case, like bringing a technologist along. And I think that we are entering this phase now where increasingly people will demonstrate an ability to look across multiple different areas, multiple different sectors, and lean upon experiences that they may have had in different ways. And so bringing those voices together and allowing for a more complete review, I think will be very advantageous for us. And convening bodies such as this panel, and certainly just as Professor Tikki has done previously at WHO, I think that these are the elements where having additional viewpoints and ability to talk about not just the impact that technology can have, but indeed the ways that governments are empowered on behalf of the beneficiaries to make an action, I think will be the work that we take on in the coming year or two post-pandemic. So thank you again to the organizers and to my panelists. This is a fantastic elevation of some of the themes that I touched upon at the beginning, and certainly learned quite a bit. So looking forward to further discussion.
Thank you very much, Andrew, for your comments on the contributions of the four panelists. I think you're re-emphasizing how technology should be used smarter is very, very relevant. I like your emphasis on not just rich countries helping LMICs, but the potential for South-South collaboration. I think we shouldn't underestimate that aspect as well. I also like very much your focus on the importance of the context, because obviously it's not just whether you have the data, but how to interpret it in terms of local context, which just, it makes me reflect on my years at the WHO working with policymakers in government. And basically, the minute you have a new technology, if you are a senior government official, and Carmen mentioned that government should be the primary agent of change here. If you are a senior official in government and you're presented with a new technology which potentially, or which everyone says is potentially beneficial, you basically ask three questions. Can it work? Will it work here? Is it worth it? Okay, so as we move from these meetings to policy outreach, I think those three messages, obviously, precision public health can work somewhere. Will it work here? That's another question. Is it worth it? Well, that's once again another issue that I think, as Jeremy mentioned earlier on, that as time goes by, the cost effectiveness hopefully would actually be improving as well. So okay, so we have a little bit of time for Q&A. I'm looking at Jeremy to help us here. if there are any questions, he's just going to jump in and ask it rather than me paraphrasing. So
All
Jeremy,
right.
over to you.
Yes, and thank you very much, Tikki. I'll just summarize the key themes of the questions. And if I can focus on two aspects. The first is, how should low and middle income countries prepare for a world of precision public health? And maybe can I add a sub question to that? If I were a young public health professional in a low and middle income country, what should I do when I see these changes happening? And the second broad suite of questions really revolves around the role of the international community, and a specific question: what can and should the Bill and Melinda Gates Foundation and other international bodies do to support low and middle income countries in the transition into precision public health? And back to you, Tikki.
Well, thank you so much, Jeremy, for helping us out on that. So this is what I'm going to do. I will sort of give each one of you, hopefully 1 or 2 minutes, to address those two questions. How should low and lower middle income countries prepare for precision public health? And what's the role of the international community? So let me sort of start again with Patrick, who'll give you a quick go at this. Patrick, you're muted.
I'm not on mute now. So yeah, it's a funny thing being a doctor working in a clinic, as you can see behind me, seeing patients one by one, because you often feel like you're at the polar opposite end of the spectrum to the public health physician. Dealing with genetic information on an individual is really drilling down to the most minute detail, potentially not actually adding a whole lot of value in some circumstances, and increasing cost of care. But I think the pandemic's really shown that genomic medicine is a solution across the entire spectrum, from the clinic right up to the public health physician. And I think public health doctors are realizing that, and themselves are training in genomic medicine. Carmencita mentioned the sequencing of viral genomes, which was done with a very rapid turnaround in New Zealand through contact tracing. And it was a very successful story, which has really raised the knowledge of the community to what genomics can in fact do. So I think, you know, for the training public health physician, I would say listen to what's being said in this meeting and by the co-panelists here, that this is an emerging technology that has a lot of scope, and it's a very fast-moving field.
What about the role of the international community, Patrick?
Yeah, the role of the international community, I've reached out a lot to the private sector, and that includes not just the private sector in New Zealand, but internationally. There are some fantastic philanthropic groups around the world, and I think the high-income countries really have an aggregate of wealth that, in fact, sitting there ready to be accessed. I think governments are probably, after the pandemic, going to be looking for what's the next thing to do, because all of their focus has been on the pandemic. That there's a real opportunity to bring in these philanthropic groups and seek funding of these programs, as has been said by some of the co-panelists, to really get them off the ground. It does seem like a lot of the health ministries, our health ministries, still very much focused on the medicine of today, not tomorrow. And it's still funding the same old, but not better use of the available data that we've got that could extend our reach right into the community, to rural settings, to the most remote places.
Okay, thank you, Patrick. So, Olivo, quick responses to how should countries prepare and the role of the international community.
Thank you. Thinking of the low-income countries that in the GMS that are endemic to malaria, and I'm thinking of really low-income countries such as Laos, Cambodia, Myanmar. We do have, I think, the real main problem is a problem of manpower and expertise on the ground. Now, it was interesting to hear Carmen's presentation, where she actually said two separate things. One is that there is a manpower problem, and she phrased it in terms of brain drain, but you know, that's a lucky problem to have. Most of these countries actually don't even have the brain to be drained in the first place. There's no training. There's very few people who've taken that sort of course of education. But then the other thing is, she said that foreign support is unsustainable, and that is ultimately true. So one has to balance the need to supply know-how, which essentially must come from outside, versus the need to be self-sustainable in the future. And I mean that must come in the long run through education, through development of the manpower. But in the short term, the way to transition, because there is a risk that this gap will in fact widen rather than close over the next few years. So over the short term, what can we do? And this ties up, I think, to the role of the international bodies that are participating in this. I can tell you what we are doing, which is we've actually identified certain areas that are particularly hard for these endemic countries to implement, and these have to do with data processing and analysis and producing results that are translatable to the control programs. And what we have done is essentially we are creating a sort of consortial model whereby we supply the informatics power, but we actually are right now transitioning the laboratory operations to the countries, such that we can do sample processing within countries, and then data can be uploaded. And as long as we've agreed on common formats, then the information basically comes out in a semi-automated way. It's still very important to have local expertise in order to talk to the control programs, to interpret the data, and so on. And I would say, finally, all this is based on networks of trust. You know, the control program doesn't really care whether you come from University of Oxford or University of whatever. They don't know whether to trust you, and it's important to have local scientists that can communicate with them, that can vouch for you, that can support the whole program. We found this to be invaluable, and until we develop the local expertise, this will remain a major problem. Thank you.
Thank you very much, Olivo. I absolutely agree with you that trust is central to this. I would just make a quick addition to the role of the international community. I think people have mentioned the role of foundations like the Bill and Melinda Gates Foundation, role of the private sector. But I think there's also a very important role for international organizations like the WHO in the context of setting norms and standards and best practices around digital health in the broadest sense. So that's something that I think maybe not just WHO, maybe other multilateral organizations can also play an important role. Okay, let me give the floor now to Carmen, your responses to how should countries prepare and the role of the international community.
So if you're in a country wherein there is a talent or a pool of expertise, then you volunteer to the government and say that you've got something to offer. That's the beginning. It's a conversation. If you belong to a country without any expertise, you have to reach out to your neighbors. You have to reach out to your friends, because we do have friends outside who are willing to help. So the important thing is that as we reach out to other countries, we also engage actually academia. This is where academia can come in, you know, where academia can be a partner in finding the solutions. So because preparing for COVID is just one, but there will be another pandemic. So I think the conversation, this is an opportunity for academia and the government to find a place for each other. As I've shown in my examples, partnering with the high-income countries or middle-income countries or low-middle-income countries is actually very important at any time of our career or life. So the collaboration actually is going to be crucial. I see now, if I link it now to the Precision Public Health, this may be something that the Precision Public Health Society in Asia can do, is to do an inventory and find out who needs help. I mean, I need help, so I'm going to reach out to Jeremy and find out what else I can do. So I think it's really the conversation that should happen. There are many groups outside, and if you belong to a country without any standards or norms, and that's the reason why we have WHO. They help us, they guide us at the beginning, but at the end of the day, we've got to situate it to our country. It's always okay to copy, but you have to check whether it's going to work in your country and whether it's sustainable. I have started many things with the help of other countries, but I have to make a conversation with my government on how I can sustain it beyond the project. Now, there was a question about if I were a young professional. You know what? This is the time to volunteer. If you want to learn from the ground, you can volunteer to the government or a private or an NGO or to the academe, and learn public health, learn precision public health from those who are implementing it right now. So at the end of the day, it's a conversation among countries, a conversation among students, among experts. And I feel that somehow we will be able to move forward together. Back to you, Tikki.
Thank you so much for your insights, especially on the young professionals. Last but not least, Tarun, your responses to the questions that Jeremy so nicely summarized for us.
Thank you, Tikki. Look, this is a terrific conversation, a really important conversation, and I absolutely agree with the previous speakers. Olivo said it really nicely about the importance of investing in your workforce. So technology, however good, is never a substitute for public health workforce. And the best, the answer to any public health question is usually workforce, 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 the first three answers. And we have seen a disinvestment in public health workforce over the last 20 years in developed and developing countries alike. And there is a risk, despite COVID, that we'll see a further disinvestment after this initial glow of COVID has gone away. So someone mentioned about keeping the momentum up, and I think that's a really important role. So if the answer is workforce and the essential public health training that we want to see rolled out, so that's all the old workforce and training initiatives, this might be an opportunity to get some more investment post-COVID into those old initiatives, if you like, some of which have languished. But I think there's a role for some more specific advocacy. And I just want to draw a particular example. In Western Australia, over the last couple of years, we've actually got a commitment from government to invest 5% of the health budget into public health and prevention on a glide path towards 2028. So over the next 10 years, the current investment is around 2%, and government has committed to increasing that to 5% over the next 10 years into prevention and public health. So that's a very specific political commitment that has been made. As president of the Public Health Association of Australia, we're now trying to get the national government to make a similar commitment to investing 5% of the Australian health budget into public health. So that's our advocacy goal. And there could be something similar we take up at a regional level. So I know that WHO has made this strong advocacy for universal health coverage. And that goes right across, and it's still not achieved yet. But if you could ally universal health coverage with a 5% investment of your health budget into public health, that then naturally flows into workforce and into being able to adopt new technologies appropriately, etc. Without that, I think you're always struggling. And the last point is, if I were a young professional coming into public health, I'd still want to do the old-fashioned training and do that to the highest standard possible. But in addition, I'd be seeking to work with other disciplines in some area of my interest. So whether that's social science or data science or some other junction with another discipline outside public health, whatever it is, whatever interests you, I think we should be giving our new public health trainees an option to work with other disciplines, because I think that's the future. Thank you.
Thank you very much, Tarun, for those insights. So I think I very much like your your message that I think in a strategic political sense, moving ahead, Jeremy's new society can play an important role in this, is to really pitch precision public health, not as a sort of a standalone new sexy technology based on the latest advances, but to really place it squarely in the context of providing universal healthcare, because that's what most countries are committed to. That's what WHO is pushing very hard. And of course, the ultimate goal is the achievement of the SDG 3, that global compact of the Sustainable Development Goal, particularly SDG 3, which focuses on health. So I think politically, strategically, that's the way to promote precision public health in the future. I'm aware, keeping track of the time, before we I try to wrap up shortly, could I just ask if any of my panelists, the 5 panelists, would like to have make any sort of closing comments. Andrew, any closing comments, messages?
No. So beside my thanks here, I think I did want to address one question in this last round with respect, I think specifically to the role that the international community and foundations like the Bill and Melinda Gates Foundation have. Right. The strategy that we put forward had largely been surrounding ways to empower those groups that have already been in country, and ideally it's for beneficiaries to gain greater agency. And I think that in that construct, ensuring that there is continued autonomy of organizations and regional organizations that can decide how best to address some of these very critical infrastructural and societal questions going forward is really the big part of this. Now, funding helps, of course, to intersect pieces of it, but I think just as many of the other speakers have mentioned, this is unsustainable. And so the expectation that international community will fund and sustain that infrastructure, I think, is folly. And so instead, it's a matter of catalyzing and ensuring that we address all of the pieces that you already heard, things like workforce, certainly some of the technologies, but ultimately, as we all have been talking about, I think it does come back to lessening that gap that Olivo was mentioning. So circumventing that lack of workforce and the ability of people to use data, I think is the critical juncture. And this last bit that Tarun mentioned, I think is incredibly, I just wanted to amplify that. I think looking at this in a multidisciplinary way and breaking down the silos between disciplines is indeed the future. And so that's a big way that we see our role from the foundation, and hopefully as the larger multilateral organizations as well start to fund and promote this precision public health initiatives, that we see the same energy going toward reducing those barriers. So thank you again for the opportunity to participate today.
Thank you, Andrew. Patrick, any last comments before we?
I would just say that I've learned a lot from the co-panelists here, and it seems crazy that we have so much data and don't use it appropriately. It's cheap, more or less almost free, and yet we still focus on the high-end tech that's costly, becomes redundant very quickly. And really, data is cheap. It's the people that we need to invest in. So it's that workforce training, and thanks to the internet, a lot of courses are online, low cost, and hopefully now government respect that, have seen what public health has done during this pandemic and funds it appropriately for the future.
Thank you, Patrick. Olivo, any last comments, remarks from you?
Yeah, perhaps I could just point back to the question about funders and international organization and their roles. I think moving forward, as data technologies are adopted in low-income countries, one problem that will have to be addressed, and I think the funders and the international organizations can actually, I think they can give some leverage there, is that there is still fundamental unfairness in the cost of adopting these technologies in low-income countries. I mean, the cost of processing a single blood spot in Vietnam is twice what it is in the UK. And everything costs more. And very often there is this perception that, you know, the technology is just too expensive to adopt. So whereas, you know, 𝗣𝗶𝗱𝗱𝗹𝗲 earlier on said, you know, the cost of sequencing, for instance, has gone down by orders of magnitude. It's true, but it's going down faster in rich countries than in poorer countries. And we have to address this and make a level playing field for the low-income countries.
Thank you, Olivo. Carmen, any last?
Well, I just wanted to say that there's really a lot of hope for us in the low and middle income countries, but we should know when to reach out. We should know how to talk to government, and we should look at ourselves as partners in looking for the solutions. I want to reach out to the young population because we need more public health experts to solve the problems of our country. So I look forward to this society being maybe a catalyst for many activities in the region. So thank you again. Back to you, Tikki.
Thanks, Carmen. Tarun, last comments.
Thanks, Tikki. Thanks, everyone. It's been a great panel. So I think in terms of the Precision Public Health Asia Society, I think that's really important in that we do need new partnerships. If we continue to do exactly what we're doing in the same kind of configuration, we'll get much the same results. And it's a pretty unequal world when you look out there. So we need new partnerships, and perhaps COVID has given us a trigger to have those kind of new discussions and new partnerships. So I absolutely feel that part of the new partnerships is with government, actually. If you look at many of the current partnerships, they fail to include government. And part of the reason is, you know, the academics get together and the institutions get together, but often who's not at the table is government and the policymakers. And partly going back to Andrew's first presentation, maybe our use cases are not sufficiently strong enough to bring government to the table. And I really think we need to work harder to bring government to the table always, as opposed to kind of sometimes. Otherwise, there will continue to be a technology academic enterprise without the policy change and the actual change you need. Thank you very much.
Thank you very much, Tarun. Well, Jeremy, can I just have another extra minute, just one or two comments?
Yeah, sure. Yes, please, Tikki. Thank you.
Okay, so I'm not going to try and summarize. I've tried to sort of give comments as people had intervened. I just maybe like to close on two, I guess, personal reflections. The first is really to pick up on what Tarun just said. It's an unequal world out there, and this issue of biases and structural inequities has been highlighted by many, by Carmen, by Andrew. So in my view, at least, the ultimate benefit of precision public health is really in reducing inequities in health. And I'm sort of reminded by what many of you may know is what you see when you enter the front building of the WHO. And that is the mission of the WHO is the attainment by all peoples of the highest possible level of health. That, to me, is the ultimate goal of precision public health, to reduce inequities, to give people with no voice, people who are poor, disadvantaged, stigmatized, etc. And the second comment, if I could can I get back to my slides? Let's see. Okay. Where am I here? Okay, so my second comment is to really pick up on what very nice saying in Andrew's presentation, that all we need to do now is to have the will. And I want to remind people of what Goethe said many, many years ago. Sorry, I can't seem to move this. Anyway, what Goethe said is, knowing is not enough, we must apply. Willing is not enough, we must do. Okay, so on that philosophical note, let me take the opportunity to thank all of you. I think I've certainly learned a lot from today's panel. So thank you for all your contributions, and back to you, Jeremy, and the organizers.
Thank you very much, Tikki. Yeah, and Kisha, over to you.
An insightful discussion. Many LMICs have a tight healthcare budget, as you have learned, with competing priorities. In some LMIC settings, retaining talent is also challenging. However, we have seen how the COVID-19 pandemic has accelerated the cross-disciplinary engagements beyond the traditional players in public health. This could possibly bring solutions for other health issues in the future. Moreover, there's also a need for the international community, including high-income countries, as well as the local LMIC governments, to support LMICs to expedite the adoption of some emerging technologies, empowering them to contextualize it locally and ensure that it is sustainable when the high-income partners leave. Also, successful LMICs can help with technology transfer to other LMICs, allowing them to use technology smarter. Ladies and gentlemen, we have now come to the end of Conference Day 1. Thank you very much for joining us. You'll be able to access the recordings for today's session through the Programs tab at the top of the page tomorrow. You may also find out more about the program for future sessions there. Once again, thank you for joining us today. We really look forward to having you online with us again for tomorrow's session, starting at 9 a.m. Singapore time, with the plenary session, Technology for Good, Why Work Together. I wish you a pleasant day ahead, and see you tomorrow.